We're still missing one member of our party who's coming right back. So we have about another hour to share our thoughts about the future of healthcare and health and healthcare. We've had some wonderful themes identified during this morning: the importance of community, importance of communication, thinking about governance, thinking about transparency and data, some discussion about accountability and accountable to whom and how. Would love to hear your voices. We're going to try to have as many voices get into this conversation as possible. There are notes being taken so that we will record for ourselves and for the organizers some of the ideas about the future of healthcare. Because as I said earlier, I think it's a really, some of the ideas here could be seeds planted for future work that Shannon and Vikas and others here are doing. So with that, I think on the stage right, audience left, you're next.
Thank you very much. I feel like this is the closest I've ever been to a revival meeting. And I don't know why that hit me, but thank you for all.
Burns is going to welcome you to the Presbyterian Church.
My name is Martin Levine. I work at a CarePoint Health now and have become an employed physician. I practice family practice 2 days a week now for 30 years, and I've taught at every level of medical education, having started family medicine residency programs and still have third and fourth year students in my office, teach first and second years in a variety of medical schools, both allopathic and osteopathic. And I'm a past president of the American Osteopathic Association. But I'm here because of the words of someone who spoke at a commencement speech, and I think it ties in very well. He said that essential to your, he was speaking to the graduates, essential to your medical education is the primacy of the whole human being, integrating body, mind, community, as well as culture. I am here largely because of enormous admiration for this type of pedagogy. And he said, you are far better equipped to serve the health needs of the American people than graduates from allopathic medical schools. And he was, of course, talking to the University of New England College of Osteopathic Medicine graduates. And I bring that up because I was sitting at one point at a meeting nationally of the AMA Gifts to Physicians from Industry Task Force. Very interesting group. Led by several industry leaders on the pharma side, as well as durable medical goods people. And we had a very excellent presentation by the then president of AAMC, Jordy Cohn, who said no contact at all, no pens, no paper, nothing. The person leading the group was a past president of the AMA and began to yell at him, to which Jordy then started yelling at him, and I had my hand up, and nobody cared, and basically I finally got their attention. I said, I have a question for you. Can you separate what you just said from what is actually going on in the allopathic medical schools, that you are the president of the group that belongs, et cetera? And that is, would you take your third and fourth year medical students out of the hospitals where they give noon lectures sponsored by pharma? And he said, well, you can't do that. You couldn't separate that. What are you talking about? And I said, and you know, the durable medical goods people come in and help with surgery in hip replacements and other things to show the physicians how to do that. Would you separate? And by the way, that was when the new hip prosthesis, which has since been taken off the market, was going into effect. So my question is, would you take the names off the buildings that were given to you at these institutions and the research dollars that you get directly to your physicians in these medical schools and separate yourself so that there is that transparency? And of course, there was no answer to that statement. But what I've seen with the almost more than 30% increase in allopathic and osteopathic medical schools is that the allopathic medical schools are still going into that research-directed medical schools and the production of about 90 to 95% of their graduates not going into primary care by any definition of what that is, whereas you see the osteopathic medical schools going into Hattiesburg, Mississippi, Dothan, Alabama, Blacksburg, Virginia, Yakima, Washington, and partnering with the community health systems there, getting to that community health. We're seeing a little bit more money going toward the community health systems with the teaching health centers. But my plea is, how can we change that medical education for the vast majority? And we will be somewhere around 20% to 25% of the graduates will be osteopathic, so we can hopefully rely on about 50% of them going into primary care. But the question is, what can we do about the other 75% of the graduates, 90% of them going into that specialty?
Great question to almost everybody in the room. And I think our panel I've asked them all to think about, what's the one thing you would do tomorrow to get us on the path to the place that you'd like us to be 25 years ago. I'm not asking you to answer it again.
No, I'm not. I forgot to say that the person speaking at the commencement was Dr. Bernard Lown.
That's good. That is important. No, I welcome brief interruptions, but we have lots of people standing up. So I'm going to try to really encourage you to keep your comments concise into one topic. If you want to talk about a different topic, come back again, because otherwise the people at the back of the line aren't going to get to say anything, even given the time we have. So yes, go ahead.
My name is Alan Joseph. I'm a first-year medical student at Brown University in Providence. Dr. Lee, I really appreciated your comments on this pragmatic optimism, but my question to the attending physicians in the room, all of whom are wonderful teachers, I'm sure, is how do you get medical students of public health, students in pharmacy, whatever they may be, involved in making that systems change now? A number of attending physicians will tell you, wait till you're done. That's a decade from now. I don't want to wait. I would like to start, I don't have to do full-time research. I don't have to be in a free clinic 40 hours a week. But how can I be involved now? And how can I go through my medical education remembering that medical care and health care aren't the same thing? So how do we do that? How do you get medical students, whoever, or any other students involved in that? I would love your thoughts. Thank you.
Let's take a quick comment. Go ahead, Dick, did you want to say something?
I'm chair of environmental health sciences at UCLA, and I have this endless battle with my public health faculty. Half of them say, we want to grow researchers, and the other half say, we want to grow practitioners. What do you want to do, Dick? And I said, I want to grow leaders. And it is so important to validate and energize our young people, because the leadership in the 21st century is going to come from you. It's not going to come from all the gray heads in this room.
Couldn't agree.
There are skills in quality improvement and in followership that can also be taught. The most important person in a movement is the second person, not the first person. And how can we be participants in real change?
I think there are lots of opportunities. I think there are lots of opportunities for medical students to get, and nursing students, and pharmacy students, and others to get involved. I think a lot of it, and shame on the attendings who don't know what they are, but pushing beyond the attendings to look at the schools of public health, at the schools of public policy, to find ways of going beyond the stodgy, curriculum. Patrick.
Just a 30-second answer. Organize. Grab your students together, go to primarycareprogress.org, check out the tools there. That might not be your venue, but there's some tools anchored in core lessons on how to organize communities. The more of you there are, the more your power is in the system, and the teachers will come to you. You are powerful. Think about the Harvard Medical School example. You can change the system now. Organize.
All right. Yes.
Okay. I'm Jim Scott. I'm the president of the National Physicians Alliance. I'm a family doctor by trade. Practiced in a little town in Oregon for 20 years, and then I went to Brent James' course in 1995 and kind of had a transformation. Took on a role leading quality and safety initiatives in a large system. Then I retired from that, so in my third career, I found my medical home, which is the National Physicians Alliance. And those of you physicians who aren't already members, come see me and I'll help you sign up. And the reason you should do that is because we're an organization that's focused on exactly the themes of this meeting. It's founded around the ideas of a return to professional values and our fiduciary role as physicians, avoiding conflicts of interest and avoiding having doctors and others put into the painful position that we get into by perverse incentives, the toxic effects of the so-called market, really trying to get back to the evidence base, and then trying to provide the support to providers and patients to provide the excellent care that they should have and they deserve. And so some of that gets to Brent's point about the infrastructure. We need the infrastructure that's the IT infrastructure, that's the highly effective teams for doctors and patients to really bring them together to bring the evidence to bear and the care that they need.
Wonderful. Fewer conflicts of interest, better IT, and let's jump over here
Okay.
and introduce.
Tall biased, I think.
Yeah.
I'm Laura Newman, and I write the blog patientpov.org. I've been writing it less frequently because I need money, and it's not monetized. That's the end of my promo. What I wanted to say is, I appreciate the sincerity and the interest of all of you guys. I share a lot of these interests. Joanne knows I've written a bit about elderly health problems. But what I really feel is, we live in a youth society. People are not interested. I feel like I preach to this group. Young people don't want to know about metal and metal hips. They don't want to know about statins being overused. They're not in unions anymore, so it's a do-it-yourself Kickstarter, group. And most strikingly, I am going to write about this, with 23andMe on a group of science writers, I was hearing people saying the FDA is paternalistic. They should get out of this and get hip. And I'm talking about science and medical writers saying this. And, and yet the vast majority of people who go for that genetic stuff, it's almost like a narcissistic, let me see if I am related to Bill Clinton. And, so I sort of feel like we're up against a lot of walls. And I'd like to know how people up there think you can engage and get people to pay attention to a lot of these issues, which I don't think, we're reaching people.
We're going to get that chance at the end, when they each get to comment at the end about what they would do. And we might have a slight forgiveness, and you can say two very short things, but the most important one is, no, just one. Okay, John, over here.
Thank you. Eric Rhines, practice geriatrics in Lynn, Massachusetts at PACE, P-A-C-E, Program for All-Inclusive Care of Elders. My dream for the future is already happening a little bit. So many of my patients have the same thing, post-traumatic stress disorder, then alcoholism and drug abuse, lung disease from smoking, diabetes, hypertension, heart disease. And seeing them all individually, it seems such a shame. They all share so many of the same stories. Getting them together would be so wonderful. And at our PACE currently, we do have a group that meets, a life skills group. Several of them want to get together and they talk together, and it's wonderful the support they get from that. It's a facilitated meeting. When I was at Harvard Community Health Plan, we had a group patient visits, which I understand are still going on. The problems are there's HIPAA rules, and then in patients supporting each other, they bring up techniques that might not be FDA approved. And then when it's in a medical setting, you get a little worried. So I wish that some of the rules and regulations would allow more freedom of patient support to each other, as you've talked about in communities. Well, there was more, but thank you.
Wonderful points about linking people together. We've heard a little bit about that this morning already. Especially people who share common problems. The amazing thing about emerging facilitated networks is those are lots of the patient networks are supporting each other without any of the rest of us professionals in the chat. and doing it very well.
Nigel BJ from the Cleveland Clinic in Abu Dhabi. This morning we've heard some great things about citizenship, participation, community engagement, and these are all really important themes. I'm just going to give you a tiny story. I was born in the UK, and when I went through medical school, I was 18. When I was 18, I went to a clinic, and I put out my arm, and they took a pint of blood from me, okay? And I went away, and I felt very good about being a doctor. Many years later, I came to the United States, and I went to give some blood, and I was paid for the blood, okay? And it reminded me, because I did some work on social policy, about a very seminal work by Richard Titmuss, published over 40 years ago, called The Gift Relationship, which was about blood, where he, rightly or wrongly, began to look at different societies and how they thought about altruism and giving things, and this relates to love. So my question really is going back to this key thing that we're talking about here today, this reintegration of health and healthcare in the 21st century. And I don't have an answer, but I have a question, which I want everybody here to think about and reflect and generate more questions. And the question is, how do we get to the stage where people in the United States will be able to give blood freely as a volunteer without all the wastage and the expense that is associated with blood transfusion currently? I think that is a slight kernel that can be used to begin to address this question.
What a wonderful thought experiment. We should all be thinking about that.
Hello, everyone. I'm Nancy Cresson from Boston University School of Medicine in the VA here in Boston. And I think I want to speak as a patient to this vision of 25 years from now. Years ago, I worked for a dentist who, in his records, documented at the top of his notes a few personal facts about every patient that he could then refer to when they came for another visit and made them feel known to him. And I wish that for my medical record, so that when I go see my primary care doctor, she'll remember again, and if I get a referral to a specialist, things about me will be known, so that I don't have to recite my history and who I am over and over again, and also that the goals for my care be clear, or somewhat clear, what kind of person I am, values around care and volume of care and so forth. And I take a little hope from a couple things that are happening in the VA in this regard. First off, in the VA now we have an Office of Patient-Centered Care, or I forget its exact title, and there's been a real thrust to have providers start with patients by asking a question that is, I'm not going to get it exactly right, but it's something like, who are you and what are your goals? And secondly, coming up in the VA is sort of a new project focused on developing measures, performance measures, patient-centered performance measures. And I'm thinking that these things can be integrated, and Dr. James, they can be transparent and move across platforms, like Reverend Stanfield, you talked about your wife not having all this information. So those are some of my visions for 25 years from now.
Wonderful. The question of how, we haven't heard a lot from the patient's perspective about what care should look like. So those of you who have thoughts about that, pile on. The other perspectives, I haven't heard much about what's the future role of government, what's the future role of physician organizations, a little bit of that, but think about the other perspectives that we haven't heard, because I think we're all in this together, and what's the role for industry? Is there a role for industry? Do we just get rid of it? I'm not sure how you can run a health system without products that actually participate, that are useful to us. So think about the other perspective, other ideas that we haven't heard or thought about what that future should look like. And now I can't remember which side I was on here. Great.
Hi, I'm Richard Young from the John Peter Smith Family Medicine Residency Program in Fort Worth. I have a comment and a question. My comment is that several people have talked about healthcare as a right. And I think if you look at, let's say, Western Europe, where it is a right, it is there, but it's a limited right. And frankly, Dr. Berwick was flat wrong yesterday when he said there's no deprivation in those countries. Now, deprivation is a very strong word, But the fact of the matter is the NHS makes decisions not to pay for certain drugs and tests and so forth simply because they cost too much. And there's a much better balance between the needs of the healthcare system versus the needs of the other pieces of society. So my question is and in contrast to the US culture, where Medicare is not allowed to include cost in its coverage determinations. So my question is, for those of you who think about single payer as the answer, do you also talk about at the same time how to set limits, and then sort of correlate to that, how do we get Medicare to start to consider cost in its coverage determinations?
Challenging questions. Should there be rationing? Does there need to be rationing? And of course, from my biased perspective from a lot of work, I think we're wasting so much money, it's immoral to deny potentially beneficial treatments to folks, but then that's just a narrow parochial perspective.
George Maxted with the Tufts University Family Medicine Residency at Cambridge Health Alliance. I don't have a blog or I'm not a member of any organization that you need to join, but I do have a dream.
Imagine.
And that is that we realize that the future of healthcare is not in this room. It's out there, and we've heard some discussion about medical students and residents, and I guess I just can't emphasize that enough from my perspective, that is where the future lies. We have 24 residents at the Tufts Family Medicine Residency out at the Malden Clinic that are seeing patients today. And they're still seeing them in the model that I grew up in. There were some comments yesterday about the Flexner revolution and how we need to change that. I really think we need to get serious about that. Many of you have probably seen this really nice graphic by Carr White, the ecology of healthcare, in which the body of people that are going to access healthcare is so big, but then the squares get smaller and smaller as they access more narrow realms of healthcare until you get to the very bottom, which is about the 3 to 4% of people who end up in a hospital. But where do all of our resources go? And even more importantly, where are we training our medical students and residents? In that little tiny box in the corner of nothing, of this great world of healthcare. So I really think we need to get residents and medical students out of the hospital, basically is what I'm saying. I see a world in the future where a futurist, Leland Kaiser, once described it as hospitals without walls. Maybe we don't need hospitals. We don't need 81 hospitals in Massachusetts with 250,000 beds. We need to vision a future where that isn't the case, and where not only are patients being treated outside of those walls, but we're training people outside those walls. We're inviting them into patient-centered medical homes. And we're really revolutionizing the way we not only take care of patients, but how we train doctors. To me, that's the most important thing.
Are there any other people here besides physicians?
Me.
Other health professions? So other health professions that we need to hear from, who might be part of, who have a perspective we'd like to add to this. So I saw a hand raised who happens to be right there. Welcome.
I'm a nurse, and maybe the scariest kind to some people because I'm a liberated, retired nurse.
Hey, we need you in New Hampshire and Vermont, where we're launching parish nurses to sort of.
Sorry, I belong to Maine.
Revolutionize Maine as well.
My name's Kathy Day, and I just told you who I am. I've advocated for patients all my life as a nurse, and now I do my best to bring patients' voice to these conversations. So the conversations this morning and the words that I love hearing in the same few hours are healthcare is a human right and love, which is not a word we hear very often in healthcare. But when we boil everything down, it's about the patient and about our love for humanity, and it's the reason we do our work. So my hope and my vision for the future is to remove some of the complexity in both health care and health care benefits. And I have just a quick story to share. My father retired from a mill in Millinocket, Maine, which is 70 miles north of Bangor, and he got great retirement benefits. He got health care. My mother didn't have a worry in the world when he died in 2005 of a hospital-acquired infection. That's what brought me to this work, by the way. And this year they decided, the people that owned the mill at the time my father retired, they decided they'd change those benefits. And it's for the survivors and retirees. Most of the people affected are in their 80s and 90s. My mother has early dementia. She tossed the paperwork aside, and if I hadn't heard from my aunt, who lives down the street, that this change was taking place, I would have known nothing about it. So I found out about it. I did all the necessary work. The final phone call to make this change for my mother took 4.5 hours. I challenge anyone here to find an 87-year-old person, there are some, granted, but not many, who could handle a 4.5-hour conversation about insurance. So that's a perfect example of the complexity. It's a great benefit. She's going to still have good coverage, but it's crazy, the complexity. So I just love the idea of healthcare as a human right, of a single-payer plan, and we can learn from all the problems that other single-payer plans have. So I'm just really excited about some of the conversations that are happening here today. Thank you.
Great. We're going to try to keep everybody up in the conversation. You guys are getting ready for your single suggestion of what we do tomorrow to make this a better world. You only get one. Yeah. Organize. You can say organize. I won't make it be one word, but you can. But although it's not a bad idea. So over here, Brenda.
Hi, Brenda Sorovich from Dartmouth and the White River Junction VA, and I'm sorry, I am a doctor. I felt like I should step out of the line.
No. I'm encouraging other voices to join us if importantly.
So my vision for the future is not going to sound very visionary, because I think one of the things that we really are challenged to do well is measurement. And I think that what our system works towards is the things that we measure well. And I'm going to throw out a few straw men that I've heard in the last day or two. So one of them is money, and I think everyone in this room agrees that the profit motive is not the right one, and that is certainly embedded now. But I also think spending the least money is not the right measure either. I've heard, you've heard a little bit, some of you, what I said yesterday about process measures, quality measures of process, which I think come from a good place, but are very flawed. They're typically one-sided, they're distracting, they're not prioritized, and I don't think we've done a good job of figuring out whether they're a net positive or negative. I mean, they may be a net positive, but I don't think we know that. I've heard people talk about, well, we just have to provide care that is evidence-based and has a chance of helping someone. And I'm sorry, I'm going on a little too long. That's not really right, because when we talk about care that's not going to help, it's an average, right? We're talking about, on average, doing X test is not going to help. There are people on either side of the seesaw. So I just think we have to be careful when we're kind of dismissing a whole bunch of stuff that we say is not going to help. We have started to measure satisfaction, and I think a lot of people have concerns about that for reasons I won't get into. And finally, the thing that we have hung our hats on as physicians for years is measuring death, because we know when it happens. Right? We can say, yes, this person is dead. And I think a lot of what we've heard in the last day and a half is that's not the right measure either. Do we really want to prevent everyone from dying? Do we want to keep them alive for their 31 days after their surgery so they're not getting into the post-op mortality number and various things? So anyway, just to sum up, I think one of our huge challenges is to develop measures that are well aligned with our objectives and to figure out before we implement them what the unintended consequences might be. And I don't think we have good ways of measuring what good health care is, what a good doctor is. I challenge the people in medical education to help us figure that out? Because I do think that the person who spoke, 2 people before me, that it's all about education, right? And finally, I'm going to give a shout out to the woman in the yellow pants from the Prevention Institute to say what we really need to be measuring is health, right? At a population level. And are we trying to do that? How can we do that better to inform how our system works? Okay, thank you.
Great questions. A set of questions that we really hadn't touched on yet is what should we be measuring in the future?
My name is Tanner Caverly. I'm from the University of Michigan. I'm a aspiring health services researcher. I'm a fellow at the VA in Ann Arbor. And I have a question, an actual question I'm hoping to get an answer to from Brent James. I was really inspired by your comments about transparency can be transformational and really change the water we swim in. And you talked about how being transparent about indications, and it reminded me of a story from David Foster Wallace. He gave a speech to a group of graduating students, and it was called "What is Water?" And the story starts with 2 young fish swimming in the water in the ocean, and an older fish swims by and he says, "How's the water, boys?" And the young fish swim along for a little while longer, and one of the young fish says to the other one, "What the hell is water?" And the point of that story was that the water we swim in, we have no idea it exists because it's all around us and we can't see it and it's invisible to us. And I think it's hard to imagine how data and this information could be very transformative, and if you change the water we swim in. So that was what it was inspiring. And my question is there any part of your transparency program at Intermountain Healthcare that includes the actual benefits, trying to measure the actual, or estimate the actual benefits of I think a lot about cancer screening in particular. What's the actual benefit of that cancer screening test for that patient? How does that stack up to the actual harm so a patient can understand, is it worth it, as opposed to just you're 50 and you have a colon and it's indicated?
Brent, I'm going to ask you to hold the answer to that.
Okay.
But I think we're going to have several people who want to probably pitch in on this issue. So I'm going to take a couple more comments, then we're going to start a little bit of what would we do, and if you want to take advantage of your what would you do, and there was one question that someone asked that I really want to answer, that will be your excuse to do it. So let's try to rapidly move through a few more, and then we'll start to hear from the panel again with their final thoughts, and there may be time, if they're quick, for a few bullets about what you guys think the most important next step is to do in getting to the future we need to see. So go ahead.
Thank you. My name is Dan Bednarz. I'm a sociologist and a health policy analyst. I want to talk, and I'll be very brief. There are several exogenous forces at work that have been sort of mentioned here, but they're ecological, thermodynamic, by that I mean energy crisis, acidic oceans, et cetera, interacting with politics, finance, the economy, given that medicine is totally dependent on these other systems, and all systems are totally dependent upon the Earth systems, to what extent does that enter into your thinking about the future of health systems? Thank you.
We had a little bit of that from Dick earlier about how dependent we are on these systems. So it's a great challenge to all of us as we think beyond our narrow mental models in healthcare to the broader national, global political influences.
Thank you. My name's Nadia Chambers. I work with Health Education England. Yesterday, I posted the following on Facebook. Anyone who thinks that the NHS should follow a market model needs to be here at this conference listening to American healthcare professionals and academics, a place where healthcare has been hijacked by the corporations. We must not let the NHS go down this road. I haven't got time to read you the replies, but with that in mind, and knowing that where America leads, we are apt to follow, I'd like to give you my wish list. I'd like you to create a narrative. You know the nightmare vision. I'd like to see details of the hopeful future, the values that underpin it, and the energy that keeps it alive. I'd like you to show me what you think integrated health and social care teams look like, that are part of communities where everybody has a voice. I'd like you to think seriously about funding healthcare collectively and do it because you're proud to do it, because you see it as your role as a citizen and that you trust your government to administer it appropriately. And I'd like you, Patrick, to organise, create strong networks with distributed leadership and work towards a set of agreed actions that you can measure, and I'm really looking forward to it.
Obviously a manifesto that resonated with both the panel and with the audience. Manoj.
Yeah, great. My name is Manoj Jain. I'm from Memphis, Tennessee, and I'm also the medical director at the Quality Improvement Organization, QIO. Some of you may know that QIOs are funded by Medicare to work at state level to improve the quality. And I think they're really a sort of a hidden treasure that we don't know about. In ways, I do talks across the state, and I begin my talk by saying, I'm here from the government, and I'm here to help you. And in Tennessee, that does not go well. But I'll tell you, the QIOs are a hidden resource that when we have the measures, we talked about the measures, we need to implement them. And if you think about where we were 25 years ago with beta blocker use, with less than 40% beta blocker being used post-MI, now we are over 95%. A lot of the credit goes to the quality improvement organizations and the government. Yes, the government was part of it to make that happen. And so when we come up with these wonderful ideas, and then we come up with the measures, then we have to come up with a strategy of how to implement. And the 900-pound gorilla in the room with us is Medicare, CMS, where a collective action can be done. And so one thought is, we talked about end-of-life care. Why not begin with a measure in end-of-life care? Diane Meyer and I were talking yesterday in relation to how we do this as a measure, end-of-life care, put it together for Medicare patients. So, a few thoughts.
Great question. I bet Joanne will have some ideas about that. Let's take one more question, then I want to hear some thoughts from the panel, and then depending on how we are doing with time, we'll come back. But go ahead.
Hi, I'm Marcia Hams from Community Catalyst. We're a national healthcare consumer organization, and I've worked there for many years, and at Healthcare for All here in Massachusetts for many years before that, and in labor before that. And I'm social justice chair in my Unitarian Church in Cambridge. So that's, I touch, I guess, on my vision in all of those facets of what I've done, and that is to organize, but that means to me that communities and workers are organized together to play a role in all of the change that we need to make. And we saw that that's why we have the ACA. That's why we passed the healthcare bill in Massachusetts. That was people working at the community level in GBIO together to make those steps. And we've focused a lot to get to the point where we can expand access. And now many of us are getting very involved in how the delivery system should be organized. What should we be doing about the right kind of care? But my vision is really that that's a partnership at every level that we can make that happen, because the consumer voice, the organized community has to be part of that conversation if we're going to get to the right solution. I thought Joanne's ideas about community-based care planning were fantastic. That it's in that way that we have both political power, and frankly, that's one of the things that makes people healthy. That you can be engaged, that you can that you can make a difference as a person with your community, not only as an individual patient, but in that broader context of power and love.
Thank you. Wow. I'm going to start the other side because Patrick has to leave at 11:30. So when he stands up to walk out, it's not because he's irritated at what you said, Joanne. It's because he's got to be teaching, I think, momentarily. So Patrick, a comment about what you think the next important thing to do is, and if you want to say a couple, one or two other things about what you think resonated with this particular morning.
Sure. I think just begin with gratitude and gratitude and say thank you for the tremendous visions and challenges that we've heard from the audience today. I think that's that in itself is probably the most important part of this session. I'm going to focus just a couple of remarks around education. So if we believe that there's a better way to teach the next generation of health professionals, not just doctors, but across the board, and that way focuses on the relationship between those professionals and the people they're going to serve, not the rotation they're moving through, not the specialty, not the specific skill, but the relationship, as we heard from Dave Hirsch yesterday with the integrated clerkship model. That may not be the only way, but it could be one way, and it's a specific, well-established model that could be enacted more broadly. It's spreading now, it could spread faster, and there may be other actions we wish to take. But if these are the kinds of ways that we already know we can teach better, let's think about how we make them happen. Going back to the point I made earlier, I think there is a source of power that we are not yet using that can bring leverage on key decision makers, like the deans of schools, who may be close to wanting to do this and needing the political cover to do so. So here's my what you could do tomorrow. If you identify yourself as working on this side of the ocean, whichever ocean direction you're thinking about, if your focus is domestic and you're not as aware of the global health community, think about your immediate surroundings. Find somebody who is and have a conversation with them about this problem. If the reverse is true, if you identify yourself with part of the global health community, think about those in your institution or your local environment who might be able to affect change in education, and have a conversation with them. And let's bridge that, that gap between global health and primary health care at home. Let's bridge that gap between thinking about the most meaningful teaching and the most meaningful practice. Let's actually get our leaders in the education institutions to do what they want to do, what they know is the right thing to do, but they need help acting against the incentives that they feel, as all of us do. So let's connect. Thank you.
Great suggestion. Conversation. Great suggestion. Brent.
Just out of curiosity, how many of you use the internet? Yeah, I thought so. Is it fair to say that it's fundamentally transformed our existence? Was that a committee decision? Was that an organizing question to create the internet? I was actually there when it was built, by the way.
With our former vice president.
To really date myself, no. I was on the original ARPANET when we had 8 computers back as an undergraduate in physics at the University of Utah, and then watched the thing develop.
Gracefully, Brent.
Yeah. There you go. I'm going to stick with the infrastructure piece. And the internet's probably one of the best examples you could probably see. I've seen that work repeatedly. I don't need to change people's morals. What was it that Mark Twain said? Nothing so needs reforming as other people's morals. I don't think that's it. I think you make it easy to do it right. And that's the key function of leadership. It's more of a service model. People have used the word love a lot, but I'd rather use the word service. How do you serve? How do you make it easy to do it right? And frankly, one of the most important things we could do today is to get those data systems up. Now, you need to know that the current set of data systems out there, one in particular, the big dominant one, is an anachronism of the past. It tends to lock in many of the major problems that we have today.
I don't think Judy's here. You can talk about it.
Well, if Judy were here, I'd still be happy to talk about it. And so I'm devoting a considerable part of my time in creating that next generation. Yeah. It's one of those fundamental shifts that just makes it easier for everybody to do what they would like to do. And by the way, relative to the question, there are a set of design principles. I prefer to use Ed Deming's design principles. Design is the key element of a good data system, and you can address the issues that you raised with proper design. And that's a long technical discussion for those who are way into geekdom.
And you can email Brent for those design principles.
So, there we go.
That's great. So information's, pay attention to information to make the work easier and to do the right thing. Joanne.
Yes.
You guys are going to get a turn. They're being crisp. This is really good.
It's always a challenge when you say, just the one thing you want to do. So I'll start with some place you don't think that we'd start with. When a child is born, everywhere in the United States, there are 6 questions that have to be answered by the delivering physician, and they go into the national database. They're the things you might expect. How far ahead of the birth was the mother in prenatal care and so forth. I want to do the same thing for death. As one gentleman was saying, it's the thing we can find. We generally know, not entirely exactly, but pretty close, when people die. I want to have 6 things made part of the record, and whoever's around at the time of death has to figure them out. And then they have to get back to everybody who took care of this person in the preceding year or two. It's actually fairly simple. 83% of us die covered by Medicare. So we know a whole lot about who touched this person, at least on the medical care side. We wouldn't necessarily know the Meals on Wheels provider, but it's a start. But it would mean that you would ask things like, did the person have a coherent care plan? Was it written down and available across settings? Is the family reporting, or if you've got the patient to do a YouTube before he died, you can have the patient reporting. Did it serve the patient's priorities? Is this what the patient most wanted to achieve in the last few years of life? You could even do a bit of a quiz to the upstream providers and say, does it change how you see things? I think it would create a tremendous amount of fuel. And then in the same sort of way that I'm talking about community, you would obviously want those. Remember, there's no privacy rights after you're dead. So let's combine these for a community. How well are we doing? Which things are coming up all the time? Let's use this as the fuel to fix things for that sickest, most fragile part of your life those last few years. And so maybe a sort of an odd way to go about it, but it starts requiring things like organizing communities, like having care plans, like actually knowing how our patients and our families live. People were talking about medical education. I think one of the most important things about medical education would be to get it into the home. Just being there. I used to take medical students out with me, and I'd say, we're going to leave shortly after we get there. Come with me. And I'd say, forgot my stethoscope. I've got to go back to the car. And I'd say, okay, so start telling me all the things that you've already learned, and think about how you could not have learned them in the office. You could not have learned how this apartment smells. You couldn't learn how people relate to each other. You couldn't learn what the neighborhood is like. You got to get out there where people are living in order to really make a difference, and to realize that the person's locked in a 3rd floor walk-up and can't get out in a fire, or can't get out for any reason. I think that that would be the sort of thing that would be a high leverage change and bring a lot of things out into the open and require that we solve problems that right now we're trying hard to keep avoiding.
Wonderful. End-of-life information that's fed back to everybody about what's happening with frailty and at the end of life. Fire away. See you, Patrick. Dick. Dick.
One of my faculty is Jared Diamond, who wrote the book Collapse, and you could tell listening to me that I have a pretty bleak vision of things going forward, but I don't really. Despite the climate shift, despite the deindustrializations, despite the crowding, America will do the right thing. And it's really important that health leaders and folks of your goodwill, intelligence, and love be involved with it. I do think that changes in the physical environment need to happen. And when I teach course, I talk about the built environment is social policy in concrete. And what you build, and I did a video series, and for example, we visit 20 cities over the course of a couple years. You go to Syracuse, and they put a highway right down the middle of Syracuse. They put all the poor people on one side and the wealthy people on the other side. Basically ruined the health of the people on the wrong side of the freeway. These things are going to change, and I think that we are going to build an America that's much, much smarter for a lot of reasons. 57% of the people looking to buy a house in the United States today do not want the leafy house in the suburbs. They want to be in a walkable community. And these are the people, and it's young people who want to be in a bright place and a lively place to raise their children, and it's older folks that don't want to be car dependent to go about their lives. So my wish list, there's a New Yorker cartoon way back in the day, and it's 2 guys, and one of them's opening up the cabinet, and he says, "Oh, this is my Bureau of Alcohol, Tobacco, and Firearms." And I think actually
alcohol, firearms in every house
in America,
a chicken in every pot.
So we tax alcohol, not enough, and it helps. We tax tobacco, and it's helped a lot. We ought to be taxing firearms, And we ought to particularly be taxing at a very high level, large-scale magazine clips, and maybe we should be taxing ammunition in a far more profound way. That certainly would not bring up the...
That's the top one on your list, is better tax policy.
The better tax policy, and I'm going to give you two more...
Okay. All right, well, we're having to create exceptions as we go along here.
All right.
So...
No, better tax policy, but the other things to tax are, we've got to tax carbon. You know, Americans are really smart about building vehicles and building homes once we begin to tax carbon. And this is not a big issue. This is a health issue, and we've got to do it. And the last is, we've got to tax fructose. And campaigning against sugar is not smart. It puts you in a difficult position. But everybody knows that fructose is just like ethanol in terms of being toxic to the liver. And if we make fructose much more expensive, it will change what we're doing. Then the money that we get from this, I'm sorry, geriatricians, I don't want it spent on anybody else but kids, because we have given our kids such a raw deal. And we ought to be using this money for safe routes to schools, for decent nutrition and PE programs for our kids, and for really training, helping our kids not be burdened with enormous amounts of taxes when they finish schooling. And this is where the money ought to be spent.
Very good.
And we can certainly afford it, because there's tons of money wasted in this damn healthcare system right now, so we could just take the money and shift it there.
Tons of money spent on fructose.
Anyway, Mark.
Well, Elliot, I got to go with two things.
I knew it.
You know,
Okay.
there's a practical, and then
everyone else is going to be jealous.
Was so inspired by the religious folks here today that there has to be a spiritual thing to do
so
tomorrow.
one spiritual, one practical.
So the practical is that I would do everything, that I would ask the federal government to do everything in its power to encourage state-level innovation in 2017 under the Affordable Care Act, and to, in particular, encourage partnerships between the kind of rights-based organizing, grassroots organizing that's going on in a number of states about, you know, expanding health care as a fundamental right, which the ACA has not done in any way, with the communities that are looking at new innovations in care, more holistic approaches to health care, social factors relating to health, and to really use those state laboratories as innovation. I think you can build movements in the states towards change that you can't build nationally at this moment, and I think that those movements can drive change, and you can move in very, you know, from places like Vermont, which is really, you know, smaller than I lived in the Bronx for a lot of years. It's smaller than my neighborhood,
Beside that, it's up near that communist country up to the north, but go ahead.
But then, you know, to California, which would be the game changer in terms of, you know, setting up, you know, restructuring an entire healthcare system. So that would be the practical thing. I think there's a lot of levers at the command of the federal government. I'm quite unhopeful that they're going to use those levers, but I think that that would be a real opportunity to drive change in the immediate future. And then I guess the spiritual promotion side of this thing, and I heard it from a lot of folks here today, is to really promote a culture of solidarity, to counterbalance this culture of consumer-driven, you're in it by yourself, you got to cut the best deal, you need to evaluate all social programs in terms of the immediate loss and gain that you as an individual or maybe your family members may experience. You know, it's a very distorted way of looking at things. People feel so much better when they are empowered to act on behalf of a community, and it just changes the way we relate to one another and the way we look at social policy and we look at the world. So, I would urge that component of a solidarity culture really be part of everything that we do. So those are two interrelated things.
Wonderful. State level innovation and solidarity.
And thank you for the precedent, because I want to slip in two as well.
You should go for three.
The first, I'm a pastor. The first is to pray. And I don't mean that just in a tongue-in-cheek way. One of the great things about praying to the divine, it's been my experience, is not just asking what the divine will do, but how the divine changes me. I love the image of the sweat lodges, and I realize that in my neighborhood of Southie, they're not sweat lodges, they're AA meetings. And there's amazing stuff that happens there. It's been probably one of my biggest places of learning the last 22 years. So first is pray. Next step, because I'm also an organizer, is to be civically engaged. And the key for that is relationship. We hear organizing, and that word gets thrown around a lot, and sometimes we think organizing means finding people that think like I do and let's have a march. And that's not what I'm thinking, and it's not what I've learned from broad-based organizing. Organizing is having public relationships with people, developing trust, finding common interest. There are people in my community that watch Fox News all the time and agree with me politically all the time. We still develop trust and find the things that we can work on together as a community, as a congregation in my case, and politically as well. And so I think having those conversations, having those kind of relationships are vital not only to our society, not only to healthcare, but to democracy, as I was trying to say before. Those relationships, ideally in a mediating institution, to use that phrase from de Tocqueville, unions, congregations, bowling leagues, wherever we can find them. And they're harder to find them now than they used to be, which is why our kind of organizing is working so hard to nurture congregations as that place. And I'll close with this story. This fall, for the fifth year in a row, we take teenagers from our neighborhood, and like I mentioned before, it's mainly from 2 local housing projects where the rate of voting has been low historically. And we train them in civic engagement. We train them in having one-on-one meetings with people. We train them in saying, listen to what people want to make their community better. And we train them to go door to door and encourage people to vote. Because the politicians pay attention to neighborhoods where people vote. It's not rocket science, They pay attention. You can get a printout on this internet thing, and you can see who votes. So we tell that to the kids, even though they're not old enough to vote yet. So they've been doing that, and sure enough, over the last 5 years, the number of ballots cast has increased. And this year, it increased again, significantly compared to 8 years ago, and reasonably compared to 4 years ago, last time there was a municipal election. And sure enough, 2 weeks after, the newly elected mayor of Boston came to our church, and we're not a huge church, 100, 150 people, came to our church because he noticed that. And he congratulated the kids, and he brought the Boston Herald so they could be photographed, and he could be photographed. And that is that's civic engagement. And I'm thrilled that the kids got to see that. I'm also thrilled that our parishioners, with their different viewpoints, could once again be reminded that what matters is being engaged. I think our democracy needs it, and I think our health needs it. Good.
We need to hear your one idea, too.
I was actually, thank you, Brent. I was going to take the moderator's perspective to say, Dr. Fisher, what do you think? This has been an amazing conversation. I think there are 3 things, stealing precedent's been set, that I would actually think would encourage people to do, and it's really about us here in this room. The first is I would really encourage you to read the work of Elinor Ostrom. She's the 2009 Nobel Prize laureate in economics, and did her work on what it takes to overcome the tragedy of the commons. And the challenge of forestries, fisheries, water basins, and she showed that it is possible for communities to come together to solve these very complex, difficult social problems. And the insights that she has, I think, are just deeply relevant to almost everything that we've talked about today. The notion of stewardship, which is a word she never used, but her whole career's work is about stewardship. It's also, I think, states are one level at which work needs to happen, but what her insight is that most of the places where there are problems, whether it's healthcare markets or pollution or the Los Angeles water basin, cut across geopolitical boundaries and are not going to be solved simply by the political entities that are responsible for different components, so that you need structures of governance that can manage a community's issues. And that the notion of community has touched here, but we haven't heard about the tools that you can use to do better there. And I think Ostrom's work, I just commend it to everybody. I think everyone also needs here to learn how to do the work that Marshall Ganz has obviously taught several people on this panel how to do. Ganz is a community organizer at the Kennedy School. His PhD thesis I would not recommend to you because it's just too hard to read. I don't know whether you tried reading it. I gave up. But the work on how to do effective community organizing through storytelling, just some of what we've heard today, the story of me, the story of us, the story of now, each story having 3 pieces to it: challenge, hope, and choice. And then the second piece of organizing, which is asking people through relationship to join you in commitment to something beyond yourself. Those are very powerful tools that I think if everyone here went out and read 2 things, looked up and learned a little bit from 2 things, that would, for me, be huge. And I think, Patrick pushed this, and I think it's really important. Think globally, but act locally. It's an old phrase, but so much of healthcare is local. Health is local. It's all produced, from the social and behavioral determinants of the little communities within which we live, and by the healthcare systems that are robbing the money from those places because they're building new silver palaces. And we have to have new conversations with the leaders of those health systems so they become stewards of their community, not stewards of a glass palace. This has been an amazing and wonderful panel. Most of you, how many of you have heard of Wayne Gretzky? Right? Everybody's heard of Wayne Gretzky. So, one of his famous statements is, skate to where the puck's going to be. And that's clearly one of the elements that we've heard from this morning's panel. The second, I think my favorite is, you miss 100% of the shots you don't take. You miss 100% of the shots you don't take. And if everyone out and went forth from here and took 1 shot, it'll be pretty amazing. And to wrap up, we've actually had 6 hockey players on the. We got a team here. I'm the coach outside there for the moment, but we got a hockey team here, right? 6 great, a goalie and 5 others. They're not a man down. They were all here, and so I want to thank our amazing panel, the first line of this hockey team. And so thank you guys for doing this, and I hope you'll all join me in thanking them for this work. And I think there are 2 things that I want to do. One is I want to announce again that the town hall meeting, those of you who volunteered and missed my first announcement of this, it's going to be happening on this floor in the back. Walk through the back and you'll be able to find where to go for it. But the town hall, those of you who've agreed to participate in the mock town hall, please find your way there. In the federal room. After all this talk of local action, we're going to the federal room. But you're going to the federal room. That's great. And then I think we can turn this over to the next portion of the agenda. So thank you very much.
Thank you.
Thanks.
Elliot, thank you. That was terrific, and we're delighted that you were able to join us.